Okay, this is a lecture on introduction to hand and wrist for first year medical students. So we're going to identify the prominent features of the bony structures. We're going to talk about the joints, including all of the significant attachments. We're going to describe some of the vascular supply, including listing all the attachments. And some of that's covered in a different lecture. We're going to describe some of the nerve pathology and movements that occur at these joints. And here is a list of the structures that the medical students are expected to know. I'm not going to read them all. You can pause this if you want. All right, and one more caveat, I'm not an anatomist, I'm a clinical physician, so please forgive me if I misspeak on any of the anatomy. So we're talking about all the components of the joint, right? So there's the articular surfaces of the bone, there's the capsule bursa, there's ligaments, muscles, and tendons that wrap around the joints. And then you need to understand the movement in biomechanics and then how it is innervated and vascularized. So let's start with the bony constituents of the elbow joint. Here you see the proximal elbow as it articulates right here. So here's the trochlear notch, which will of course articulate with the distal humerus. Then there's some other attachments or bony structures you should know, right? Radial notch for the radial head we see here. And what else do I like on this slide? Tuberosity, supinator crest, right? These are bony landmarks for muscles. And then the olecranon on the posterior surface here, seen laterally, is the bony part of the posterior elbow. When we look at the distal humerus, you see the trochlea, which you could guess goes in the trochlear notch, right, of the ulna. And then you see the capitellum, which articulates with the radial head, right? So there's really two different joints there that make up the elbow hinge joint, and also the proximal radial ulnar joint is part of that. You can see the supracondylar ridges here, the lateral and medial epicondyle, a couple of fossa here. And on the back here, you see the olecranon fossa on the posterior view, which is also noteworthy. Radial tuberosity, big landmark. Okay, so here we see it all come together, right? So this is the anterior view of the elbow and extension, trochlea sitting in the trochlear notch, capitellum sitting here next to the head of the radius, forming the joint, and then this radial notch on the ulna is where the radial head also sits, and this is the proximal radial ulnar joint, which is not really how it's labeled. When you look posteriorly, you can now see the olecranon, right, which is on the back of the ulna. Then you don't see it very well, but the trochlea in the trochlear notch here, which is really the major hinge joint. The groove of the ulnar nerve, right, which is interesting. Then here's another view of that. I think I'll just look at the x-ray here, which is sort of a more clinical way to think about it. So this is a standard PA view of the elbow and extension. And you're seeing the radial head here. You're seeing the ulna here coming up, and that's the trochlear notch kind of that you're seeing posteriorly, and the olecranon behind the humerus, which is here in front of the ulna, of course, and that's why they have the trochlea marks right here, the capitellum here, humerus, radius, ulna, and then all the other landmarks, right? So supracondylar ridge on the medial and lateral side, medial and lateral epicondyle, etc. The ligaments and capsules keep it all together. So here's some noteworthy ones, right? Annular ligament of the radius, right? Very important one. The ulnar collateral ligament, so UCL, sometimes called the MCL, and the radial collateral ligament, sometimes called the lateral collateral ligament of the elbow. People get those confused with the knee, so we usually use radial and ulnar for that reason. Here are the fat pads, okay? And these are sort of cushions inside the capsule, and you will note that the synovial membrane wraps around them. And so remember that the fat pad is intra-articular. We will talk about that later. And this whole thing forms the capsule, okay? Here's looking at it from a lateral and medial view. So again, here's the annular ligament. Here is the radial collateral ligament. Here is the ulnar collateral ligament right here. It's got a couple different branches. You can see the bicep brachii tendon coming down here on the radial tuberosity. And what else do we like on this slide? Basically it. Okay, here is a sagittal sort of cross section of the elbow when it's accompanying x-ray, which is a nice view. So coming down here, humerus fat pad. So again, here's the fat on the posterior and anterior side. Again, it's within the synovium. And so if you have a joint effusion, for whatever reason, trauma, gout, infection, you get this posterior displacement of the fat pad here, which you can see as a silhouette radiographically on a lateral elbow x-ray. Not on this one because it's not pathologic. But you do see the anterior fat pad here, which is marked anterior fat pad. And if you go over here, same thing. However, the anterior fat pad is not pathologic by itself. And so that can be physiologic. Triceps tendon, here's the olecranon bursa. No, I'm sorry, that is not the olecranon bursa, though. That is a separate bursa. The trochlea sitting in the trochlear notch. You can see the blue stuff is the articular cartilage, okay? The capsule wraps around the synovium, okay? The synovial membrane and the synovial fluid. Coronoid process on the front. All right, and then you see all these things on this same view here, but just in bony form, right? So capitellum, et cetera, trochlear notch, olecranon process. And here is another sort of view of the joint itself. Not a lot of new pictures here. What do I want to point out on this slide? I think just thinking about the articulation is helpful. So remember, the capitellum goes to the radial head, and the trochlea goes in the trochlear notch. And then the ligaments that we just talked about hold it all together, including the annular ligament, the ulnar collateral ligament, the radial ligament. Those all go over the capsule, and then the synovial membrane here, which is marked, and then the synovial fluid sort of keeps it all lubricated. Here's some movement of the joint. So proximal radial ulnar joint, right? So there is an articulation here, right? So instead of having one big hinge joint like the knee, you have this extra bone articulating at the joint, right? So there is a fibula, but the fibula doesn't really go into the knee joint as it is classically defined. And so here you actually have three bones in articulation. And what this allows you to do is have pronation and supination, right? So the radial ulnar joint really allows for more than just flexion and extension. So classically, it's a hinge joint, but it also has pronation and supination, and a lot of that has to do with the radial ulnar joint here, and the radius not being a hinge component, right? And then there's, of course, a bunch of muscles that do that. The supinator muscle can be seen here, right? And that, of course, contracts and supinates into the anatomic plane. And then you have a few pronators, which do the opposite, right? Neurovascular supply, right, from the brachial, profunda brachii, radial, and ulnar arteries. The elbow is mainly innervated by branches of the radial and musculocutaneous nerves, and less commonly ulnar and median. Then we talked about the movement. All right. Here's some images of the neurovascular structures, right? So radial nerve coming down laterally, anterior to the joint, the median nerve coming down right down the middle, okay? And the ulnar nerve coming down just behind the medial epicondyle. So in the right view with an ultrasound, you can find all three of these nerves in front of the elbow fairly easily. There's other places that you can find them reliably as well. Now the radial nerve is going to bifurcate right at about the radius into the deep and superficial branch of the radial nerve, okay? And then the median nerve is going to do the same thing a little farther down the forearm, and you get the anterior interosseous nerve coming off of it. Now, if you go all the way down the forearm, right, you have the proximal radial ulnar joint. You also have a distal radial ulnar joint, which essentially is the same concept, right? It is an articular joint between the two bones, distal radius, distal ulna, but also they make up the wrist. But the radial ulnar joint is what participates in a lot of the supination and pronation, okay? That's why there's a quadratus muscle all the way down here at the DRUJ, okay? The wrist joint, let's see. We're gonna talk about the wrist, I guess. So you have the palmar, there's a lot of slides on ligaments because there's so many of them, it's so busy. So there's the palmar radiocarpal ligament, so named. We're going from the radius carpus. There's the ulnar collateral ligament, which is part of the triangular fibrocartilage complex, the TFCC here. And then there's the radial collateral ligament. Okay. So getting into the bony view before we get into ligaments, the joint, if you talk about the wrist joint, you're talking about the ulna, the radius, the scaphoid, the lunate, and the triquetrum, right? That is the anatomic definition, the proximal row here of the carpus and the ulna and radius. Okay. So those articulate with each other. And here we're seeing palmar and dorsal view for clarity's sake, right? And there's some anatomic landmarks worth mentioning. There's styloid process of the ulna. There's also a styloid process of the radius. Okay, there's a radial tubercle here distally. The groove for the ECU. What else do we want to talk about? The Book of Hamate is always a fun landmark to remember. And most of these other things are just showing attachments of the muscles. Okay. And here we see that radiographically, okay, unlabeled and then labeled on the right. So we're seeing the scaphoid, lunate, and triquetrum. That really is what makes up the proximal row of Julia's arc, right? And then the pisiform radiographically is sitting more or less over the triquetrum. And then the distal row, you have the trapezium at the thumb, okay? And then the trapezoid, the capitate is the big one in the middle, and then the hamate and the hook of hamate, okay? So that is the radiographic view, and this is, of course, a normal X-ray. Here we are, again, trying to go through this. So you have to memorize the carpal bones. I always remember it as some lovers try positions. Wait a minute. What is Z? Oh, I see. These letters don't correlate. So some lovers try positions that they can't handle. M should be, nope, some lovers try positions, and then I go back here, that they can't handle. Here we go, hook of hamate. So proximal row, distal row, you have to memorize that. And of course, there are joints between all these, right? So the midcarpal lines, also called Goulia's arc, you know, they label, so the piezo-triquetral joint, right? There's little joints between all of these. The scapholunate joint is one of the ones that's really important and is pathologic if that ligament is interrupted. Okay, so what else do we see here? We see the articular disc. So think of this as a meniscus between the lunate and the ulna, and it can be injured just like the meniscus in your knee, right? So that's, again, part of the triangular fibrocartilage complex of the ulnar side of the wrist here that is often involved with pathology. They're showing us here some of the articular cartilage, the synovium, synovial fluid. Okay, and of course, all of this has synovium. All of these little carpal bones have joint fluid between them. Okay, and then of course these joints and the joint capsule are reinforced by a ton of ligaments. There's so many, right? You have to be a hand surgeon to have memorized all these, right? Look at just ulnar triquetral, ulnar capitate, and ulnar lunate, right? That's wild. Just the ulna alone, right? There's basically a ligament to every other carpal bone from the other. So the one that I think is probably the most important, let's see, is we want the dorsal scapholunate ligament here. This little guy is probably the most important one, because if you tear that, you get scapholunate dissociation, which initially doesn't cause any problems, but leads to biomechanical dysfunction, and eventually you get scapholunate advanced collapse and really bad arthritis. So here's some more worth mentioning, right? So the star dorsal radiocarpal ligament, volar radiocarpal ligament. So I think clustering them is helpful instead of getting lost in all the sauce here of the little tiny intercarpal ligaments. And then you have, of course, the radial collateral ligament with the green here, right, on the radius side. If you're ever confused, remember the thumb is radial. Radius distally is the big bone. Ulna distally is the little bone. And then the ulnar carpal ligaments here, right? Ulnar collateral ligament, excuse me. And then we have a bunch of important structures, right? So here's a volar wrist here with the flexor retinaculum over it. And then this is the sort of superficial layer. And then this is cutting down some of the tendons, right? So there's the flexor digitorum profundus, which is the deep, and the flexor digitorum superficialis, which of course is superficial, right? So that's flexor to the digits 2 through 4. And over here you have your FPL and your FCU and some of the other flexor. Okay, all this stuff is flexor because it's on the flexor surface, and then in the middle is the median nerve, which of course can get compressed under the flexor retinaculum. You see the radial artery over here, not pictured as the radial nerve, which runs adjacent to it. You see the ulnar artery over here, which will traverse through Guillen's canal with the ulnar nerve. Okay, and then these two come together to form the palmar arch, right? And the anastomose. So here's another picture of that anastomosis. There's a deep and superficial palmar arch that you have to know. So wrist flexion extension, and then really think of it as radial and ulnar deviation. You can call it abduction and adduction. That is technically correct. However, that is not the commonly used vernacular. Neurovascular supply, right? dorsal and palmar carpal arches, which are derived from the ulnar radial arteries via this anastomosis, right? Median nerve, radial nerve, ulnar nerve, right? They all contribute as they spread out into smaller and smaller nerves in the distal limb. Okay, let's get into the fun part. So, a mother tugs on her 5-year-old son's hand to pull him out of a path of an oncoming car. The child immediately screams in pain and won't move his right arm. Radiographs obtained in the emergency department reveal a dislocation of the radial head. Which of the following ligaments was most likely associated with this injury? The annular ligament, maybe. The joint capsule, that would be a heck of an injury. Radial collateral ligament, maybe. Radial side, radial head dislocation. Medial collateral ligament, well, that's on the ulnar side, right? That's the ulnar collateral ligament, so probably not. And then the interosseous ligamentar membrane, probably not. So the answer is the annular ligament, which I hinted at earlier, which anchors the radial head into the distal radial ulnar joint, or sorry, the proximal radial ulnar joint and the elbow joints in total. So it's often called a nursemaid's elbow, but subluxation of the radial head. This is a tugging injury, right? So you have traction on the child's forearm in an immature annular ligament, and it can sort of sublux, out a lot, and then it can dislocate where it doesn't pop back in, and it's sitting sort of radial or lateral to the annular ligament. And you have to reduce that. The most classic method, and it really isn't that hard, is called hyperpronation, where you just push on the radial head and you really pronate them, and that pulls the radial head medially, and you can often reduce that. It's very gratifying because the child will all of a sudden be able to move their arm normally, and the best way to test that is with a popsicle. A 53-year-old tennis player visits the outpatient clinic with pain all over the lateral epicondyle of her right elbow. Physical exam is positive for tenderness at the lateral elbow, and she is diagnosed with lateral epicondylitis. Which of the following tests will help confirm this diagnosis? Well, 1, nerve conduction study. Well, lateral epicondylitis is not a nerve problem. Well, not classically. Worsening pain with flexion and extension of the elbow. Well, the muscles at the lateral epicondyle do not do flexion and extension of the elbow. Worsening pain with wrist extension against resistance. So that sounds like a good guess. Numbness and tingling of the 4th and 5th digit with wrist flexion. That would be an ulnar nerve type distribution. And tenderness of the radial styloid process with contraction of the brachioradialis. That is also different. So the answer is worsening pain with wrist extension against resistance. So lateral epicondylitis is all about 4 or 5 extensor tendons all apply in or extensor muscles all attach in a common extensor tendon to the lateral epicondyle. ECRB is most famously the pathologic component, but of course they can all contribute. There's a tendinopathy, and really we call it epicondylitis. It's really epicondylalgia. It's more of a chronic problem, rarely an acute problem, although it can be, and almost universally overuse, okay? Think about sports. Also, though, piano, typing, manual labor, a lot of patients get this who do not play sports. It is a clinical diagnosis. The treatment is NSAIDs, right? Anti-inflammatories, even though it's not a true tendinitis, classic sense. Start with the easy stuff, topical and oral. PT, physical therapy, a brace. There are some special braces. Corticosteroid injection, maybe second or third line. Activity modification, right? Discontinue the offending activity. And then if you're not getting better with a significant amount of this, right? If you're really refractory, then you can do a needle tenotomy. You can do a surgical tenotomy. You have a lot of options for sort of third or fourth line. Medial epicondylitis is the mirror image of this, right? So it's on the medial epicondyle. People call it golfer's elbow. And it is tendinopathy of the flexors of the wrist and forearm, okay? Same treatment plan, okay? Causes a little bit different, but still racket sports. You treat it almost exactly the same. Ulnar collateral ligament injury, okay? This is Brock Purdy. He's an NFL quarterback getting tackled during a game. They hit his elbow while he was, his shoulder is externally rotated and abducted, and his elbow is flexed 90 degrees, and he is trying to throw the ball forward while getting tackled. And what that is stressing, if you can imagine, on the anterior part of this guy's elbow right here, is that the ulnar collateral ligament is stabilizing the ulnar side of the elbow, and it is under duress from these two opposing force vectors. Okay, so it is unfortunately injured in a mechanism like this, and in this case, he had to come out of the game, and the 49ers lost. But it can be either chronic from repetitive microtrauma, think baseball pitcher, or acute direct trauma, such as is this case, or some even more violent trauma, like an elbow dislocation or from surgical intervention, okay? You can clinically diagnose it by having them stressed, or by stressing that ligament, and then comparing it to the unaffected arm. Diagnosis is with MRI arthrogram, meaning you put contrast in the joint before the MRI, or with ultrasound. And in some cases, you can do non-operative, right? It depends on their occupation, the mechanism of injury, etc. But complete ruptures are often considered surgical, failure of conservative therapy. Okay. Okay. Elbow fractures. All right, here we see a radial head fracture, okay? This is a minimally displaced one. And here's the anterior fat pad sign we see on the lateral view we talked about earlier. That can be normal. Here's the posterior fat pad, okay? So the other fat pad on the back side of the elbow is now displaced posteriorly on this lateral view because of this fracture is causing swelling inside the joint and distending it. That's the most common adult elbow fracture. In a kid, which this is a child, you see a supracondylar fracture here, and that is the most common cause of a posterior fat pad in a kid. In this case, this is pretty obvious, but they can be subtle. So here you go again, posterior fat pad sign. If you have it on both sides, it's sometimes called a sail sign, like the sail of a sailboat. There's also the radiocapitellar line, so sometimes it can be subtle, and you can measure through the midshaft of the radius and into the capitellum here. Elbow dislocations are not subtle, right? This is pretty dramatic. You can see the olecranon here is not forming a normal contour with the distal humerus in the arm here. Mechanism is usually a fouche, where that force vector goes right through the elbow when it's partially flexed. So that's just when it's the most vulnerable. And these of course need to be reduced and often have surgical problems or soft tissue injuries that will require surgery down the road. A 70-year-old woman fell after missing a step at home and injured her right wrist. Radiographs obtained in the ED show a distal radius fracture. The distal fragment is displaced volarly relative to the proximal fragment. What is the commonly used eponymous name of this injury? So this is a distal fragment displaced volarly relative to the proximal fragment. Okay. Volarly. So this would be a Smith's fracture. Okay. So what's the difference between a Smith's and a colles? Well, colles is up here. Colles is number one. Here's a lateral view. Best way to think about it. Dorsally displaced relative to the proximal fragment. Okay. You always name the distal fragment relative to the proximal. That's the correct anatomic radiographic description. So colles fracture, fouche, force vector goes through the wrist, but it goes from, like, this guy's falling down, but the truth is the ground is pushing back. A force vector is going posteriorly and towards his face almost, and that goes right through the distal radius, as opposed to a Smith's fracture, where you now have volar displacement of that radius, distal radius component. And this, although this is not how people always fall, think of this as a force vector is now going through a flexed wrist instead of an extended wrist, which inverts the injury pattern. Okay, so colles fracture is the most common fracture in all comers. If you get into the pediatrics and geriatrics, you can sort of nuance that out a little bit. Just if you take all patients from birth to death, this is the most common injury. Fouche, fall on outstretched hand. X-ray can make the diagnosis. Sometimes CT is useful to clarify the bony fragments. Some of them can be managed non-surgically if it's extra-articular, minimally shortened, displaced, and angulated. Some patients are just really old. They're not good surgical candidates. However, a lot of them do require surgery. The complications are exhaustive. They're not always present. Most patients do well, but just think about the median nerve here on the front and some of the stress that it can be under with all the swelling and bony movement. In the emergency department, this is one of the things that we would often do because we see so many of them. This is going to be a hematoma block. So this is what it looks like before the reduction, right? Resting on this table. Obvious dorsal displacement, right? So here's the radius coming down, and then you see this dorsal displacement. On X-ray, this is a similar view, right? You see dorsal displacement of this fragment, and then here's a PA view, which you also see is clearly broken. Widen scapholunate space right there on that view too, by the way. So then you come over here and you do a hematoma block. So you're dropping the needle right into that fragment, right, the bony fracture part. You're just dropping some lidocaine in there, and that's called a hematoma block. You literally are trying to put the lidocaine or anesthetic into the hematoma, and that helps you reduce it. And then here's your post-reduction film, right? So here's your lateral, which gives you a great view of the distal radius. You really don't see much displacement. Clearly still broken. You can see the fracture fragments, but it looks much better than the original view. A 17-year-old football player is tackled awkwardly and lands on his wrist and extension. He has a sudden onset of pain and is taken to urgent care, where he is diagnosed with a non-displaced fracture of a bone in the anatomic snuff box. Which of the following bones is likely fractured? Styloid process of the ulna. Well, that's over here. Scaphoid. Well, maybe scaphoid is right here. Trapezoid and lunate. Those lunate's over here more, and trapezoid is somewhere up here. And then the first metacarpal is right here. So by process of elimination, we can get to scaphoid. So scaphoid fracture, here's a good x-ray of a scaphoid fracture, very clear demarcation. Typically fouche with some extension and radial deviation. And so rather than the force vector going through the distal radius, some of it ends up in the scaphoid. The problem here is that 80% of the bone gets retrograde blood flow, meaning that the the radial artery comes down and some branches come off of it, and then that blood flow tracks from distal to proximal. That makes it highly susceptible to avascular necrosis. These can be occult, meaning you do have a fracture, but it's not displaced and it's very subtle or not even apparent on initial x-ray. So sometimes in the ED or anywhere, you will splint these and re-x-ray them in 1 or 2 weeks. Non-operative, in some cases, if they're stable and non-displaced, that decision is typically made by a hand surgeon. These can have bad outcomes if they don't heal well, but you immobilize them in a thumb spica splint, brace, or cast. And then a lot of them require surgical management, such as unstable, displaced, if they're not healing, if they have AVN. Here's some more illustrations of that, right? So fouche with a radial deviation, you can also get it from a punching injury, although that would not be your classic mechanism. Here's an illustration of that retrograde blood flow where it's very vulnerable down here. And then this is a cast because it's circumferential. And you can see it goes all the way down to the thumb. You don't even see the tip of the thumb, although that should be exposed here. And the scaphoid is right about here. And this is a thumb spica cast. Okay. A 22-year-old football player suffered a wrist injury after a fouche. When the anatomical snuff box is exposed in surgery, an artery is visualized crossing the fractured bone. That provides a floor to the space. Which of the following arteries was most likely visualized? I'm just going to skip all of these and say radial artery. So boxer's fracture. So I mentioned punching for scaphoid. Well, this is the most common punching injury. You get a 5th metacarpal fracture here. We call it a boxer's fracture. Very common. 5th most common fracture overall, right? So radius, number 1. This is number 5. Most of these are non-surgical, assuming that it is not open, right? Intra-articular, right? Sometimes if you go into the metacarpal phalangeal joint, that's a problem, or if there's a bunch of other hand fractures. And these patients can go on an ulnar gutter splint, right? So the boxer's fracture in metacarpal is right about here. So you just immobilize that down to mid-forearm and towards the tips of the 4th and 5th digits. And this is a splint because it is not circumferential, but it is wrapped around the 4th and 5th digit here, and that is hard plaster. A 37-year-old postpartum woman presents to your clinic with bilateral hand and wrist tingling. She states it started a few weeks before delivery and really has not improved. You suspect an entrapment neuropathy. Her Phelan's and Durkin's tests are positive. This is Durkin's, applying compression to the carpal tunnel. What is the most likely nerve being compressed in this patient? So radial nerve, not likely. Ulnar nerve, not likely. Posterior superficial branch of the radial nerve, posterior osseous nerve. Those are much smaller. Median nerve is the answer here. So on our dorsal wrist, which I left in from the previous slide deck, this is worth noting. There are 1, 2, 3, 4, 5, 6 compartments to the dorsal wrist, and they all can be pathologic. So the first one here is the extensor pollicis brevis and abductor pollicis longus, right? First dorsal compartment. That can get tenosynovitis, inflammation of the tendons. And that is what de Quervain's tenosynovitis is, okay? And then you have other ones here of all which could be pathologic for various reasons. Lister's tubercle is an important landmark on the distal radius. And then here's just an illustration of those, the dorsal view. On the volar surface, you see some of the structures we've looked at before. So the transverse carpal ligament, the flexor retinaculum. See the ulnar nerve is palmar to that, and then all of the structures, including the median nerve, are below that in the running through the tunnel. So here's Guillen's canal here with the ulnar nerve, which also has the ulnar artery there, okay? That is under the carpal ligament here. So carpal tunnel syndrome is going to follow median nerve distribution, which is class going to be the thumb, first, second, third, and half of the 4th digit. You can also have some tingling on the dorsal side, right? Number one, compressive neuropathy, affecting around 5% of all adults at some point in their life, right? So this is a very, very common condition. It is typically occupational, but also related to trauma, diabetes, pregnancy, rheumatoid arthritis. They'll have positive Tinel's, Phelan's, or Durkin's, which is typically enough to confirm your suspicions. EMG confirmation is not always needed, although if there's uncertainty from another condition, Wartenberg syndrome or ulnar neuropathy, if you're not entirely sure, maybe they have some more proximal symptoms and you think it could be a more proximal lesion, EMG is useful. Non-surgical management is a cock-up wrist splint at night, which sort of just immobilizes the carpal tunnel and helps reduce any movement. You fall asleep with it in flexion, for example, you'd be compressing that. Activity modification, right? If there's a certain trigger. Physical therapy is big. A lot of these patients would get relief from corticosteroids. PRP, platelet-rich plasma, it can be an option. Sometimes oral steroids, and there's some literature to support pyridoxine, vitamin B6. Surgical management is indicated if you're not getting better. And then, of course, if you have an acute traumatic injury, that's a different conversation. A 21-year-old fashion model has an unsightly lump on her wrist that is causing her great distress. She also reports tingling sensation on the lateral 3.5 digits of the palmar aspect of her hand. Her doctor uses his pen torch to illuminate the lump and then uses a syringe to drain its contents. What is the most likely diagnosis? Well, lipoma, that's a solid structure. Not going to be able to drain that, but it can look the same. Ganglion cyst, it's a cyst. Osteophyte, that's a bone. Synovitis, well, you could drain fluid there. You might be in the tendon when you're sticking that needle around. And then malignancy, again, unlikely. The answer is this is a ganglion cyst. They're very common on the dorsal wrist. They're often colloquially called a Bible cyst. Okay, they can occur anywhere, but this is the most common spot. The second most common spot is going to be in the popliteal fossa of the knee, called a Baker's cyst. But you can get ganglion cysts anywhere. I definitely have seen them on the volar wrist quite a few times. And just think of it as a defect somewhere in the joint capsule, allowing the synovial fluid to kind of mushroom out. And sometimes it's cosmetic, sometimes it's painful.